to have more people join us as we go along. So my name is Tolulope Adeyola, and I'm the programs manager at the Foundation for Cancer Care. And I would just like to welcome you once again to this very important discussion that we're going to be having. So this webinar is actually brought to you by the Dewdrop Support Group of Lakeshore Cancer Center, managed by the Foundation for Cancer Care. So just in case this is your first contact with us, because we know that we will have, more people beyond the foundations or beyond Lakeshore Cancer Center support group participating in this webinar, I would just like to share a little bit about who we are at the Foundation for Cancer Care and Lakeshore Cancer Center as well. So Foundation for Cancer Care is actually the non-profit arm of Lakeshore Cancer Center, which is the first private operational facility that's dedicated only to oncology in Nigeria. So the Dewdrops is actually the support group that has members, or would I say survivors from Lakeshore Cancer Center, attending. So the foundation is the non-profit arm. Foundation for Cancer Care is the non-profit arm of Lakeshore Cancer Center, and we're involved in everything that has to do with, cancer education, cancer screening, support for cancer treatment for those who need support. Basically, we're just trying to interact with our community and see how we can support our community when it comes to cancer care. So that's what the foundation does. So both organizations, in partnership, we've come together to bring this very important discussion, so that we can know the important information, about, what happens when facing recurrence, or how can we actually avoid, recurrence when it comes to facing cancer, becoming cancer-free, and then what happens? How do you ensure that you're able to build a proactive partnership with your oncologist? So as we start off the webinar, just a few things. I think it will be important for all of us to just ensure that we keep our microphones muted so that we don't interrupt the sessions or a speaker when they're speaking. If we need to speak, we can just raise our hands. As much as possible, we're going to take questions and answers by the time our speakers are through with their sessions. So you can just put your questions in the chat box during the course of the discussion, or at the end of the sessions, you raise your hand and we'll be able to take your questions. So we're really expecting that we'd have, questions from this session as much as possible. So if you want to know more about us, you can always visit our website at www.foundationforcancercare.org. And yes, if you have questions, you can reach out to us. We're also on social media. And yes, you can also reach out to us via our different email channels, which my colleagues will put in the chat box if we have any questions. So I would just like to take an icebreaker at this point.
You've muted yourself, Dr. Tolu. Muted yourself, Dr. Tolu. There we go.
Oh, I'm so sorry about that. Thank you, Dr. Iwuji. So I mentioned that before we go on, before we get to the point where, we introduce our speakers, I would just like us to take an icebreaker. I'd like to know, how are we feeling today? So you can make use of the chat box. You can use an emoji to express how you feel. You can put it in words. Let's just know what our mood is like this evening. So yeah, so the chat box is open to us. How are we feeling today? I think I'm feeling fulfilled because I was able to tick off, quite a number of things off my to-do list. So that's how I feel. But we would like to hear from everyone. How are you feeling today? How are you feeling today? Okay, so someone says, Amanda says she's feeling excited. That's good to know. Yeah, so can we have more? I need to know that you're with us here. All right, curious. That's interesting. Dr. Iwuji says she's curious. Okay, we are also curious because we're going to be learning a lot from you, Dr. Iwuji. Yeah. So can we have more? Can we have more? Oh, no, Cynthia said, I'm excited. Dr. Adaure says, I'm hopeful. This is beautiful. All right. So it's good to know that we are in high spirits. And, without taking much of our time, I would just like us to introduce our speakers. Amanda, are you on ground for that? Okay.
Yes.
Right. All right.
Hello,
So,
everyone. I don't know if you can hear me.
Yes, we can. Hello, Amanda.
Hi, everyone. Good afternoon. I would say good afternoon, good morning, or good evening from wherever you're joining us. And I hope you're having a great day. I can see from the chat that we have excited people like me, we have hopeful people, and we have people that are waiting to get impacted by what we're going to do today. So I hope that, we meet up to all your expectations. So today we will be, the topic goes facing recurrence, building a proactive partnership with your oncon. You don't go anywhere and you hear the name Dr. Iwuji and your heads don't turn. So you have the best person in town with you here. So I would go ahead to introduce our speaker for the day, who is Dr. Iwuji. Kwalimi, if you can go on, please, to the next slide. So I will be introducing our speaker, Dr. Iwuji. Dr. Iwuji is a medical oncologist, and she is also the head medical oncologist at Lakeshore Cancer Center, which is a partner to Roswell Park Cancer Institute in the US. And she specializes in the treatment of solid tumors, palliative care, and she has a strong foundation in clinical practice, research, and has a master's degree in oncology from the University of Nottingham and a PhD in cancer studies and molecular medicine from the University of Leicester. You can see all these qualifications for one person, so definitely you are in the right place. She's also a co-principal investigator of the cost-fin study, which evaluates the impact of financial navigation and financial toxicity in breast, prostate, and colorectal cancer patients. She's previously served as medical consultant at Leicester Royal Infirmary in the UK, and she's an honorary senior lecturer for the University of Leicester Medical School. All these wonderful things done by one person. I would lastly say she is passionate about global health, and she actively contributes to developing oncology services in Nigeria, teaching oncology and communication skills through Africa Partner Medical. She is a member of the steering committee of the Royal Society of Medicine's Global Cancer Program and president of the British Nigerian Oncology Group. So if we may just give Dr. Iwuji a warm welcome using your favorite emojis, a clap, a smile, something in the chat, or use the reaction buttons to welcome Dr. Iwuji. Thank you, everybody. So on next, before we have Dr. Iwuji go into her session, I would briefly introduce the next speaker who would be speaking after Dr. Iwuji. Just a brief introduction before I go straight into Dr. Iwuji's session. So if you may go ahead, let me to Dr. Adaure's slide so I can just say something about her. So Dr. Adaure is a fourth-year plastic and reconstructive surgeon at the Northwestern University in Chicago. She has earned her undergraduate degree in psychology and neuroscience from Princeton University. She also has a master's in biotechnology from Johns Hopkins University and a medical degree from the University of Michigan. Her passion for global public health began early, working with her family's organization, Mezu International Foundation in Imo State, Nigeria, to provide medical care and health education to their local community. Today, she's deeply committed to mentorship, pediatric care, and breast cancer treatment and reconstruction. Dr. Nwaba hopes to improve access to quality care for underserved communities and empower individuals with the knowledge to advocate for their own health. So Dr. Nwaba has a very special segment for us today, and I would say you have to stay to the end so that you don't miss that. So now I would hand the baton over to Dr. Iwuji to begin her session. Welcome, Dr. Iwuji.
Thank you so much. Thank you for that introduction. I don't think I've ever had a more enthusiastic introduction, so I appreciate it. I am just going to start sharing my screen. Can you all see my screen?
Yes.
Yes, yes.
Okay, great. So I don't know if this is what everybody was expecting, but I really deliberately only created 3 slides because I don't think this is a session where I wanted to be your doctor talking at you yet again. I truly feel that we're talking about proactive partnership between the person who is going through the cancer journey and their oncologist. So I think in this situation, I, as the oncologist, we as the healthcare professionals have as much to learn from the members of Dewdrop as you would want to learn from me. So the way I've structured this is that I'm going to basically use only, like I said, this is 1 out of 3 slides already, but just to talk through the cancer journey from the different angles. Because in my experience and in my understanding, when a person is diagnosed with cancer and then they come into that consultant's office, the consultant has their agenda, and then the patient has their concerns and what their goals are. And often the two do not meet. The consultant basically tells you all this wonderful medical terminology. Some of it you understand, some of it you agree with, but there's still some underlying concerns that the person who is going through the cancer journey might have that we do not address. And I think if we don't get better at bridging that communication gap, then we don't have the partnership that we're aiming for. And therefore, it makes it harder for us to have discussions about things like facing recurrence, about things like what happens to me after cancer, about things like what even is going on with me during my cancer journey. So for that reason, the way I've structured this is, yes, don't worry, I'm going to give you some information, but I think I'm going to try and keep my information to say 15, 20 minutes. And then what I would love is that as you're listening to the things I'm saying, particularly those of you who have gone through the cancer journey, or those of you who have been relatives and walked that journey with a loved one, I would really like for you to just take down what are the trigger points. I might say things that trigger you, or I might say things that remind you of something in your journey. And I would love for the end of this session to be feedback, not just questions. Yes, definitely I want questions as well, but feedback from you about how we as healthcare professionals can listen to you better, can partner with you better, and some of the things that you wish you had seen when you were going through that journey that may have made the journey easier for you. So that's why I don't think it's a situation of me just sitting here and saying to you, do X, Y, and Z to prevent the cancer coming back. I think in order for us to have a partnership, we also need to talk about how we bridge the gap in communication so that the person going through the cancer journey feels more empowered in terms of how they want that journey to go. So normally, or when I was thinking about this, I was thinking about the before, during, and after treatment. So what happens before treatment, what happens during treatment, and what happens after treatment. And I'm just going to talk through some of the things that impact recurrence in each of those stages. And then thereafter, we'll be able to see what your viewpoints are. So if we talk about before you start treatment, this is basically when somebody walks into our consultation room with the diagnosis of cancer for the first time, or even trying to figure out if they have cancer in the first place. So from our point of view as the oncologist, the fight against cancer and cancer recurrence starts right there. It starts even before we start treatment, starts even at the point of diagnosis. And that's because you have to go through the appropriate steps in investigation, in making that diagnosis, in order for us to give you the appropriate treatment. And then by getting the appropriate treatment, that's how we reduce the chances of the cancer coming back. There are a lot of buzzwords that people hear in cancer, things like remission. And a lot of people ask me, am I now in remission? How will I know when I'm in remission? And the question is, what does remission even mean? Remission is basically when, yes, you've been diagnosed with a cancer, you've gone through treatment to get rid of the cancer, to cure the cancer, and remission means that the cancer is now under control or cured, and we're now trying to keep it that way. But when someone comes into the oncology clinic and we look at all their tests and investigations, there are two branches that the treatment may go in. We can aim for curative treatment, where we want to get rid of the cancer altogether, or we may aim for symptom control or disease control. So that means that from the start of the treatment, we know we're not, unfortunately, going to be able to get rid of the cancer altogether, but we're hoping we can keep it under control for as long as possible. Now, the reason why I say this journey to prevent recurrence, even when we're aiming for curative treatment, the reason why that journey starts even before you start treatment is because if you don't take the right steps at the beginning, it impacts what happens even after you've gone through the whole curative treatment. So for ladies who find a lump in their breast, understandably, that is a very scary and terrifying time. And the problem we have is a lot of women might go to places where people say, just take out the lump, just cut off the breast, just do this, just do that. And in the heat of the moment, some people have gone ahead and had lumps removed from their breasts, or some people have had surgery to that site that was not done appropriately. And that impacts the risk of the cancer coming back afterwards, okay? And so it's very important that for the ladies who find a lump in their breast, that they go through the appropriate scans, first of all, they go through the appropriate biopsies thereafter, they do the immunohistochemistry that we always talk about, which tells us what type of breast cancer we're dealing with, and that will mean that we can tailor the treatment appropriately. Because if you have 10 women in a room with breast cancer, chances are the treatments you give to those 10 women will all be different, even if they all have the same type of breast cancer. So we always try and find out, number one, if you have a lump, we have to do the ultrasound and the mammogram to say, does this look cancerous? And then we have to do the biopsy to say, is it cancerous? And then we have to do the immunohistochemistry. And that will tell us, for example, if we need to give chemotherapy before you then go on to the surgery thereafter. And I'm going to be focusing this more in the curative setting because that has more of an impact on recurrence. So what we know is that depending on different things, like I say, whether it's a breast cancer that's being driven by hormones, so that's the PR positive or ER positive, hormone positive breast cancer, or whether it's a breast cancer that's being driven by HER2, so that's a HER2 positive breast cancer, whether it's all three of those are involved, so that's triple positive, or whether none of those are involved, triple negative, all of those things have an impact on the chances of the cancer coming back afterwards. The patients who have triple negative breast cancer, so that's a breast cancer that's not being driven by either hormones or HER2, those are the breast cancers that have a higher risk of coming back in the future. And also ladies who have this condition that we call inflammatory breast cancer, they have a higher risk as well. So inflammatory breast cancer is when at the time you're coming to the clinic or the time your breast cancer is diagnosed, the breast is very large, it's very inflamed, it's red, it's heavy. You have this peau d'orange, which is when the skin of the breast looks more like an orange peel. That's a situation where the chances of recurrence is higher, right? So those are the ladies that we need to be careful about. Also, ladies who get breast cancer at a younger age. So ladies who are getting breast cancers in their 20s, their 30s, even in their 40s, we have to ask the question, why are you getting the breast cancer so early? And because getting a breast cancer at an early age also can mean that the chances of the cancer recurring are higher. And also it suggests that that breast cancer might be genetic. So we would say that ladies who get breast cancers earlier, under the age of 40, should go for genetic screening. And that's just a blood test that can be done here at Lakeshore on Mondays. So if you have a genetic screening done and you're found to have a genetic mutation that puts you at risk of breast cancer, that increases the risk of recurrence. And also, if you have other members in your family, other women, your mother, your sister, your aunt, your grandmother, if they've had breast cancer, then that also puts you at a higher risk of recurrence. And if you have any men in your family that have had a breast cancer, that puts you at risk of recurrence as well. So all these things we have to take into consideration. And if we find that you have the gene, it's most commonly the BRCA gene. It could be BRCA1 or BRCA2. But if you have that BRCA gene in your family, then the risk of recurrence is certainly higher. And that means that, again, as we're talking about curative treatment, even as we're talking about surgery, for these ladies who have the genetic risk in their family, we could offer them, instead of just having one breast removed, they might need to have both breasts removed. They might have a double mastectomy, so both breasts taken out. And some ladies choose to also have their ovaries and their womb taken out as well, because there's also a risk of cancers in that area. And so they might want to do both, remove both breasts, as well as having a hysterectomy as a means of reducing the chances of cancer coming back later on. So those are some of the things that we have to look at right at the beginning of the person's treatment. And even when the person has the surgery, I'm sure some of you are aware, we also then have to go back and say, how successful was this surgery? Did they remove all of the tumor? Was there any tumor left behind? And also we look at the lymph nodes. We check how many lymph nodes were involved when the surgery was done. So all of that will tell us what are the chances of the cancer coming back. And that's the sort of information that you need to know as ladies or people who are going through the cancer journey, so that we can say, what are the risks of the cancer coming back? And if we do all those tests and we find that there's a high risk of the cancer coming back, that's when we then have a discussion about what treatment you should have even after surgery. Should you have radiotherapy? Should you have further hormone therapy if you're hormone positive? Sometimes you need even more chemotherapy, or sometimes you need immunotherapy after the treatment as well. So those are all the things that we find out even before we start the treatment. And then during the treatment, we also have to be careful about monitoring how are you responding to the treatment, monitoring some of the side effects you're having from the treatment as well, because that will affect the duration of the treatment. So for example, if a lady is having chemotherapy and she's struggling with the side effects of the chemotherapy, then it might mean that we have to stop the chemotherapy earlier, and then that might affect the successfulness of the surgery. Now, sometimes ladies respond brilliantly to chemotherapy. We have a lady who responded really well to the chemotherapy and only had to go through the first 3 months of chemo and then go on to surgery. But that means that we have to be monitoring her very closely, as we do with all ladies, to make sure that, okay, we've done the surgery at the right time. And then when we do the surgery, we look at the response to the treatment that she received to see if we can then say she's clear, or whether she then needs further radiotherapy or chemotherapy. But the part that I really want to emphasize is after as well. So after a lady has completed all her chemotherapy, radiotherapy, a lot of the time people feel like, okay, they've just been left. You know, what's going to happen at this point? And also the truth is, I think even as we're going through the journey, whether it's before, whether it's during, whether it's after, because the burden of cancer and the emotional journey is so difficult, we don't talk about recurrence very much. And I think that's something that we need to do more. I think we need to highlight to you or to the people who are going through the journey that there is a risk of recurrence, so that they understand all the different steps that we're taking. And that's why you're monitored regularly, even after you've done the surgery, even after the doctor has said to you the cancer is all clear. It's very important that we continue to monitor you. So all those visits afterwards, when we're doing blood tests, when we're doing the scans, that's to check whether the cancer is coming back and try and catch it as early as possible if it does come back. The risk of cancer coming back when you've had curative treatment is very variable, depending on those things I said at the beginning, your age, the hormone positivity, lymph nodes, and everything. But the time when you're most likely for the cancer to come back is the first 5 years after your surgery, right? So the first 5 years are the highest risk time. But having said that, studies have shown that women's breast cancer can come back up to 20 years after they've had their curative treatment. So even though we only monitored in general for 5 years, there are some ladies that we will continue to monitor for 10 years. For some ladies on hormone treatment, we'll continue that hormone treatment for 10 years. And then even after we finish monitoring at 5 years or 10 years, it's important that the women continue to do their breast examinations and do their regular mammograms and everything. Just continue to do it yearly, because like I said, the risk hasn't disappeared. It's just a lot less than it was before. So it's very important that we're aware of that. And then in terms of what can we do to ourselves, yes, you finished all the chemotherapy and all the, highly toxic, not highly toxic, but all the drugs we give you from the hospital. What can you do for yourself? Now, the vast majority of people ask me about diet. What should I eat? What should I not eat? And all the rest of it. And that's what we're most conscious of, whether it's during treatment or after treatment. So just to give you a little bit of information about diet, studies have been done to see, particularly breast cancer, what kind of a diet reduces the risk of the cancer coming back. Now, if it's actually been shown that if you compare a Western diet that has a lot of desserts and processed foods and can be quite unhealthy, if you compare that to a diet that is just cutting out everything, so you have a lot of vegetables and then you cut down a lot of what you're eating, that doesn't have that much of an impact on your overall risk of the cancer coming back. There has been another study that suggested a quote-unquote Mediterranean diet can sometimes reduce the risk of cancer coming back. So that's a diet that's very low in fats, low in processed foods, but they have a higher amount of fish, they have a higher amount of lean meat, so things like chicken, turkey, goat meat, those things are good. A higher amount of fresh food, so fresh vegetables, fresh spices. So that's actually quite similar to our normal Nigerian diet, right? The only additional thing that they do is they have more things like cheese and yogurt. So having a normal Nigerian diet where you have fresh food but less processed food can reduce the risk of cancer coming back. And also reducing fat in your diet. It has definitely been shown that reducing the quantity of fat in your diet can certainly reduce the risk of the cancer coming back. So reduce things like chocolates and ice cream and fried foods and all those sort of things. If you reduce that from your diet, that will definitely help. But if we take aside the far and above, in terms of lifestyle changes that can truly reduce your risk of cancer coming back, studies have shown that the thing that has the number one highest impact is physical exercise, physical activity. It's been shown that having physical activity can reduce your risk of having cancer by up to 40%. 40%. And when we look at some of the drugs we use that are very expensive, things like Herceptin, things like pertuzumab, things like even pembrolizumab, immunotherapy, all these drugs that tend to cost quite a lot, they do not reduce your risk of cancer coming back by up to 40%. So just doing exercise can reduce your risk of cancer coming back by more than a lot of these expensive drugs that we struggle to pay for when you're in the clinical setting. How much exercise do you need to do? Ideally, you would do 150 minutes of moderate to vigorous exercise per week. So that means you can do vigorous exercise for 30 minutes for 5 days, or you can do 75 minutes twice a week. So things like, if you're walking, for example, don't just walk at a leisurely pace. You want to be able to make sure you build up a sweat when you're walking. If you are running, that's good. You'll definitely build up a sweat doing that. But you should also mix it with strength training. So strength training using things like weights has also been shown to be helpful. So you want to mix the cardiovascular exercise with strength training, and you want to aim to have 150 hours per week of exercise, and that has been shown to reduce the risk of recurrence of breast cancer by 40%. There are a lot of other things that seem quite obvious. Reducing alcohol intake, for those who smoke, stopping smoking as well. Those all reduce the risk of cancer coming back. But the good thing about exercise, and in fact, when they were doing the studies looking at exercise, what they found was that because when people exercise, they naturally have a healthier diet, and they naturally generally drink less alcohol, and they naturally lose weight, and they naturally eat less fat. So if you focus on the exercise part, if you seek first the exercise, then all the other things will fall into place. And so if there's one take-home thing I want to emphasize about how can you empower yourself, what can you do for yourself to reduce the chances of cancer coming back, then I would say exercise is very key. Now, the reason why I also want to hear from those of you who have gone through this journey is that it's all very well and good for me to say these things, exercise, 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 and a healthy diet. But the truth is that the vast majority of women are found, well, not the vast majority, but a large proportion of women going through the whole cancer journey, that's exactly the time you do not have the energy to exercise. You're having chemotherapy, your energy levels have gone down, you're going to hospital appointments up and down, you have a life outside the clinic. So where do you find the time to fit in all this 150 minutes of exercise? On top of that, for some of you ladies, because of the treatment we give you, you go into the menopause. And by definition, the menopause reduces your energy levels. And some of the treatments we give you make your joints ache, but ironically, exercise, again, emphasizing that, but exercise does help counter some of those symptoms of the menopause. It's just that to get yourself going to start the exercise is even more difficult. So one of the things that I was thinking that we could suggest or try and pilot as a Dewdrops group is the exercise thing. Like, how can you as a group, or how can we support you more in that? Because the best way to get yourself to exercise more and more is accountability. If you do it as a group, it helps you. You're not doing it on your own. No man is an island. So that helps people to be able to keep going, because you're meeting with people and those people are supporting you. And then by doing the exercise more, the menopausal symptoms go down. And by doing the exercise more, your endorphin levels and your energy levels start to go up as well. So that's something that I think would be useful for us to discuss as to how can people be motivated. Because when they did the studies that showed that exercise helps, they had one group of people who just were told exercise more, and then they had another group of people who actually had a personal trainer. And definitely those who had personal trainers did way better in being able to maintain the exercise, or those people who did it in a group did a lot better at being able to maintain the exercise. So for those people who have tried and haven't been able to do it, you're not alone. It's very common. It's human nature. And like I said, the whole different experiences that you're going through as a cancer patient, all those things are making it difficult for you to exercise. So it's very important that you have the support by things like personal trainers and accountability buddies and people in the group who are helping you, so that you can actually engage in the exercise better and get better outcomes. So essentially, those are the main things I wanted to highlight. One other thing I wanted to say is that as well as the exercise helping you adjust your diet as well, it also reduces the risk of this syndrome that people have. Because a lot of women, when they're trying, even though they try to control their diet, it's found that only like 1 in 10 women are able to maintain a healthy diet during and after their cancer diagnosis and treatment. So, they might have a healthy diet beforehand, but once they start cancer treatment, only 1 in 10 women are able to maintain that type of healthy diet, even from during the treatment and into after they've completed the treatment. And that means that you're more at risk of this sort of metabolic syndrome, where you become more overweight, where you have higher cholesterol, and also where your hormone levels can become more deranged. And all of those things increase the risk factors. So again, by being able to exercise, you can reduce those risk factors and your diet will naturally become more healthy as well. So at this point, I'm going to pause and stop so that we can have more interaction and questions from those of you who've been listening to say, how can we support you better in doing this? Thank you.
All right. Thank you so much, Dr. Iwuji, for that lovely session. So please, if we have questions, you can raise your hand and we'll call on you. Then you can unmute yourself and ask your questions. You can also put your questions in the chat box. So, but while we're getting ready with our questions, we wanted to also have a pre-webinar poll. And we would just like us to quickly take that poll while we're getting ready with our questions. So we have the poll in the chat box. So during the course of the webinar, you can please respond to that poll so that we also have a picture about, what's happening in terms of partnerships with our oncologists. Do you feel that your relationship with your oncologist is a true partnership? You understand? So we want to actually know that. All right. So as that is going on, please, if you have questions, you can put up your hand and we'll call on you so that you can ask your questions. And you can also put your questions in the chat box as well. Thank you. Okay, so we have a hand up.
So
That's Amanda.
in addition to Tolu's comments, I think we didn't add that Dr. Iwuji is also a board member. She's on the board of the Foundation for Cancer Care, and she basically chairs the patient selection committee where we support radiotherapy patients. So should you know anyone, or if you yourself needs radiotherapy funding or support, the foundation is available to support you in that light. So I will drop our email in the chat box, and feel free to reach out to us, and we would help you with your radiotherapy. Thank you.
Okay, thank you so much, Amanda. Okay, so we have Mrs. Olufunmilayo Akinade's hand raised. So you can unmute yourself and ask your question. Thank you. Okay, you are still muted if you're trying to speak, Mrs. Olufunmilayo.
Good evening, everyone.
Good evening.
Good evening.
Good evening, Mrs. Tolu. Good evening, Amanda. Good to hear from you. Good evening, Dr. Iwuji.
Good evening.
How are you doing?
I'm very well, thank you.
I'm
Good
Good evening. This is Cynthia
Thank
saying
you.
hello to you.
Good evening, Ma. Good evening, everyone. So, mine is a question, and my question is, I've been on the journey since 2019 from triple negative to ER positive to now HER2 negative. So my question is, why does those cells keep changing from one diagnosis, from one variant, how do I put it now, to another one? Then another, I have from my recent scan in April, I have a recurrence in the liver. And I did another CT scan this November, which is showing that it is still enlarging and the treatment is not working perfectly for it. So I want to know, is it that I didn't do the right thing, or what did I do wrong, or what could be the causes of it still reoccurring in different hormones and in different parts of the body? I don't know if you get my question.
I do.
If you understand.
I do. And I'm very, very pleased that you asked this question, because it allows me to highlight something that I really wanted to say, and I missed saying it in my talk. Even as we say you should do this, you should exercise, you should eat this, you should eat that, there is no one who has cancer or it comes back. It is not your fault. Okay? It is never your fault. Okay, so it's not because you didn't eat well, it's not because you didn't exercise well, it's not because you didn't take your medication well, it's not your fault. Some people do everything right. In fact, a lot of people do everything right, and this cancer still comes back. So of all the burdens you already have to carry with a cancer diagnosis, please do not add the burden of saying it's in any way your fault, because it isn't. Now, the thing about breast cancer and a lot of different cancers, because I'm conscious that we have some people here who might have a different diagnosis. But with breast cancer, it's what we call a very heterogeneous type of cancer. So if you have a ball of breast cancer, you might find that in one area, it's hormone positive. In another area, it's HER2 positive. In another area, it's triple negative. So we want to be able to see which one is the most, number one, which type is the majority of that ball made up from, and which of that ball is the most dangerous one, so that we can target that one as well. So it can be, so when you do a biopsy, depending on the volume of tissue you have, you can see some areas where there's hormones, some areas where there's no HER2, and it's basically which is the majority that we use for our diagnosis. So when we're giving you the treatment, we will kill off the one that we've targeted that treatment at. So for example, when you said you started off and you were triple negative, the treatment we gave you was aimed at triple negative breast cancer. But there may have been some tiny, tiny microscopic cells that were not visible to the naked eye that were breast cancer that's hormone positive. But those tiny cells will not be hit by the sort of treatment we're giving for triple negative. So that's why the triple negative breast cancer will die off, will disappear. And then at a later stage, the ones that were hormone positive, they may have been dormant before, and then they can start growing again. Or sometimes they weren't there at all. It's just because you have a bit of a predisposition and those cells will come up of their own volition at a later time. So it's either because you have a breast cancer that just has different types of cancer in it, and we've managed to kill one, and then the other one starts growing, or sometimes someone can get a different cancer altogether. In fact, sometimes, some people have breast cancer at one point and then they'll get a colorectal cancer at a completely different stage in their life. So again, it's not your fault. It's just something that's happening with the cells in the body that we cannot always control or see. Then in terms of why the cancer is not responding to treatment, cancer cells are very clever and they're trying to fight for their lives as well. So as we're treating cancers, they're also trying to find a way of fighting back. And they have many, many, many different ways of fighting back. They have ways of blocking the chemotherapy so it doesn't enter into the cancer cells. They have ways of, even as the chemotherapy enters the cell, they will immobilize it so it doesn't work, so it cannot bind to the cancer cell. They have ways of disguising themselves so that as you put the chemotherapy into the body, the chemotherapy cannot even find the cancer cells. So the cancer cells themselves, as we are giving you treatments, they're trying to find ways of avoiding the treatment we're giving. And over time, as you've had more and more different treatments, they can become sometimes better and better at recognizing those treatments and diverting them. So that's why number one, we often give, not always, but often we will give different types of chemotherapy drugs or different types of treatments so we can be attacking the cancer from different angles. And that way it's harder for the cancer to defend itself. And also over a period of time, it can sometimes get harder to treat the cancers because they have found different ways of blocking the treatment we're giving. So again, it's nothing you're doing, but we will continue working with you to find ways of that, working around the blockages that the cancer has come up with. I hope that's clear.
Okay, thank you very much.
Perfect response. Thank you so much. I'm glad with your response.
Thank you.
All right. Thank you, Dr. Iwuji. So yeah, do we have more questions? Looking through the chats, I can't see any questions. Please, if we have questions, this is a very good opportunity for us to ask. Dr. Iwuji is here with us.
And I'm seeing that a lot of people have put A and B, that they felt that their relationship with their oncologist was a true partnership, or they strongly agree or agree at least, which is great, which is really good. And I'm so pleased to see that. I'm just wondering if there's anybody who's had an experience either at Lakeshore or elsewhere where they did not feel that their relationship was a true partnership. And it'll be interesting to know what that looked like, because like I said, if we don't have a partnership, then if you don't trust your oncologist, or if the oncologist doesn't have a good rapport with you, it makes it very difficult to have a frank discussion about things like recurrence and to build trust in the relationship. So does anyone have anything to contribute about that, where they may have had a difficult or poor experience?
Okay, so we really like to hear from us. If we have, responses to Dr. Iwuji's questions, please just put up your hands. We want this to be as interactive as possible. We really want to hear from you because your feedback is also important.
Hello, good evening. Can I be heard?
Yes, we can hear you. Please go ahead.
Okay. You mentioned that the cancer cells they are struggling to survive, and so they prevent the chemotherapy from working or functioning. So, might I ask how or what can be done to prevent that, or how can we permanently, cure the cancer or attack these cancer cells without it being resistant the way it is, and further reducing the cases of reoccurrence in cancer survivors?
Okay, thank you. Thank you for that question. So, like I said, we are aware that the cancer cells are trying to resist. So, one of the ways we do it is we try and overwhelm the cancer. So, as we're giving chemotherapy, as you may be aware, we're calculating the chemotherapy we give you according to your body weight, right? And the reason we do that is because we're trying to find the highest dose of the chemotherapy that your body can tolerate safely. So the higher the dose of the chemotherapy we give, the more likely that the chemotherapy will overwhelm the defenses of the cancer. So that's one way we do it. It doesn't mean that you should tell your oncologist, give me the strongest dose. We still have to balance that against what your body can tolerate, right? So that's what we're doing when we're calculating the dose of the chemotherapy we give you. And like I said, we also try and give different types. So some ladies or some people who are being treated will have a combination of 2 drugs or 3 drugs, or sometimes we even use some people have a combination of chemotherapy and targeted therapy, or chemotherapy and immunotherapy. So we're doing that as a means of finding different ways to kill off the cancer cells. There are some studies being done to try and figure out, like you're saying, how can we get rid of the ones that are dormant, the ones that cause this recurrence after we think that the cancer has completely gone. We haven't yet fully solved that. So that's why we do surveillance and we try and catch it at an early enough stage. Because even if a lady has been cured of cancer before, if the cancer comes back, sometimes it comes back in a way that you can still give curative treatment. So that's why the surveillance is so important. It's important not to drop off the follow-up appointments. You need to stick to the follow-up appointments that are done for you every 3 months or 6 months or a year, so that if the cancer starts coming back, you catch it early enough to still be able to offer more curative treatment, as opposed to for those ladies or those patients, those people who unfortunately we don't see them, they disappear for 1 year or 2 years. By the time they come back, if the cancer has come back, it's already spread to so many different parts of the body that there's not a lot that we can do. So that's why it's a partnership, in that the doctors can't do it alone. We come up with a plan. We hope that you agree with the plan we've come up with, and then we need you to participate in that plan by, helping us with monitoring and also examining yourself. If you notice anything abnormal, then also telling us so that we can catch this thing as early as possible if it does recur. And then also complying with the things that are recommended, like the radiotherapy, chemotherapy, all those treatments that are recommended. The reason we're doing it is so that we can reduce the chances of this coming back by killing off as many of those cells as possible. So that's why for some people, they had chemotherapy first, then they had, even after the surgery, they had radiotherapy, because chemotherapy goes throughout the whole body, killing all the cancer cells. After you have the surgery, if we say you need radiotherapy, it's because, yes, the surgery has removed the cancer from that area. What we want to do is use radiotherapy to zap that area and kill off any cells that are still there that we cannot see. So that's one way we reduce the risk of recurrence. And then sometimes we'll still give you treatment after that, like, tamoxifen or letrozole or palbociclib or, all those different drugs that we give after the surgery. The reason we give those is so that they can still be killing off those cells that have a risk of coming back.
Okay, I understand. But I also have a question, because when you were talking, you mentioned majorly just chemotherapy and radiotherapy, but there are other types of cancer treatments that, I don't really hear much of, like immunotherapy, and one that has to do with light, photo something. I can't quite remember the name right now. I can't quite remember. Okay, photodynamic therapy, yes. And
Okay.
I just want to know, do you know about these other cancer treatments, and how I want to know more about this cancer treatment and how they are effective, and the rate of effectiveness, and is it better than chemotherapy and radiotherapy? Because these two also have side effects on the patients and can lead to other disease conditions, majorly
Okay.
malnutrition. I just want to understand.
That's fine. No,
about?
it's a good question. So yes, we are very familiar with immunotherapy, and we've used immunotherapy to treat a number of patients at Lakeshore. So we do use immunotherapy to treat patients. It's just that not every cancer responds to immunotherapy. So whenever we see somebody, again, like I said about getting the right tests done at the beginning, there's some breast cancers or cancers, some cancers in general that respond to immunotherapy and some that do not. So we have to check, does the person meet the criteria for immunotherapy? And if they do, we offer it. Immunotherapy is a lot more expensive than chemotherapy and radiotherapy. So some people who might be eligible for it might not be able to afford it, but we certainly do use it, and we certainly have used it in patients at Lakeshore and seen some good responses to immunotherapy. In terms of photodynamic therapy, then no, that is not something we offer. It's not something that has a lot of evidence, at least not a lot of empirical evidence, and therefore it's not really approved in most cancers. But what you can do instead, there's radiotherapy, but there's also things like radiofrequency ablation or transarterial chemoembolization that we do refer our patients for. But again, it depends on the type of cancer that you have. So there's some questions in the chat box. I think I can just say I'll read them. The first question is, when can someone say she is free of cancer? Because I've been following up with my appointments and I place on 6-month appointments. So that's a very good question. And actually, it's a more difficult question than we can say. You're free of cancer when we're doing the scans and we can't see anything. That means you're cancer free. But the reason it's important for you to continue with your 6-month appointments is, even if you're cancer free, we need to make sure that you stay cancer free and the cancer doesn't come back. So like I said, we would generally insist or recommend that you continue with your appointments for at least 5 years. But a lot of our ladies or patients who are going through the cancer journey, they will continue beyond that 5 years, because we cannot predict. Remember, I said that the cancer can come back even after 20 years. I reject it. I pray that doesn't happen to anyone here, but it's not impossible for that to happen. So you're cancer-free when your doctor says, we can't see any more cancer on the scans. That's when you're cancer-free, and that's a wonderful time, and enjoy it. And by God's grace, you will stay cancer-free. It's not everybody that has a cancer and it will come back, okay? A lot of people have cancer and they have curative treatment and it never comes back. But we have to be vigilant because that risk is still there. We're trying to reduce the risk as much as possible. That's why we give all the treatments. I hope that answers that question. If not, then please put it in the chat box. The next question is, I think one of the reasons why resistance occurs is because of the break during treatment, either due to financial constraints, side effects, or inadequate information on the treatment plan. Very true. How can this partnership be improved so there is no break during treatment? How can we include alternative medicine in cancer treatment? Both, all very excellent points. So that is absolutely correct. When someone is going through treatment and the aim is to cure the cancer, it is extremely important that we avoid gaps in their treatments. Because like I said, we can get the cancer cells are fighting back. We want to just keep on hitting them regularly, pummeling them so that they die as effectively as possible. So when you have gaps in the treatment, that can actually reduce the efficacy, the efficiency of the treatment. Now, if someone is struggling with side effects, it's not their fault, right? So again, I keep saying it's not your fault, it's not your fault, it's not their fault. And we as doctors sometimes have to make the decision that, okay, because your blood count is so low, it would be dangerous for us to continue the treatment at this point. But that means that by the time you come to your next treatment, we might need to reduce the dose of that treatment so that it's better to have a lower dose of treatment and have that treatment consistently every week or every 3 weeks than trying to push with a higher dose of the treatment, and you have it this week and then you fall ill for 2 to 3 weeks, then you have it the next time and then you fall ill for 6 weeks. So that's how you deal with the side effects, is by adjusting the dose of the treatment if the person is struggling with side effects. In terms of financial constraints, that is very, very difficult. And we are trying to do a study at Lakeshore, the cost-fin study, where we're trying to see how can we support people better in managing their finances. And we're looking into things like, NGOs that can support. We're looking into things like signing up for NHIA health insurance to see if that can help as well. So we're trying, and like I think it was Amanda that highlighted this. We're offering, the foundation does offer these radiotherapy treatments as a means, to subsidize the radiotherapy treatment so that those who cannot afford it will be able to still get the radiotherapy treatment that they need. So we're doing our best to partner, but it is very, very difficult because a lot of these drugs are being brought in from abroad. And that makes, especially if we want the genuine ones, that makes it harder for us to reduce the costs. So those, I think the ways the partnership can be improved would be by, like I said, feeding back to us when you're having side effects so we can manage them and reduce the gaps in your treatment, and then seeing if you can join on to things like the cost-fin study. For those of you who are at this stage, unfortunately, you might not qualify for the cost-fin study, but at the beginning of your treatment, and even if you're struggling, just let us know. I know a lot of you do and you go to front desk, but we'll do our best to partner with that. Then in terms of inadequate information on the treatment plan, we try and give you the information, but I really want to say that if you feel that we're giving you information on the treatment plan that you don't understand or doesn't make sense, then ask. Keep asking. And if, for example, we're doing your chemotherapy clinic and you have questions or you're having side effects, don't feel shy to ask the questions so that we can address those issues that you have, so that you understand. That's why I said, again, it's a partnership. If you understand what we're doing and why we're doing it, you're more likely to stick to the plan, and that will give you better outcomes. Then also alternative medicine. Yes, alternative medicine in cancer treatment does have a role. What I would say is I'm not one of these people that doesn't believe alternative medicine works. I think the part that I get concerned about is if you're taking medications that might interact with the chemotherapy or with whatever drugs we're giving you and cause more side effects. That's concerning. And also, unfortunately, research into alternative medicine is very limited. But what I would say is that we know that things like reflexology and things like, oh my goodness, what's the other one called? Reflexology and homeopathy and acupuncture. Those three things have been shown to help if you do them alongside, not as an alternative, but alongside the chemotherapy, because they can help reduce the side effects and increase the efficacy. So, I mean, I came from the NHS in the UK, and I know certainly in the NHS, we were offering reflexology, acupuncture, and homeopathy alongside the cancer treatment to improve patients' outcomes. So there's definitely a role. We just need more information. Another question is, hi, doctor, I was diagnosed months ago with rectal cancer. My recent CT scan came back clear. However, my concern is that I've been advised to get very frequent MRI scans, which shows soft tissues better, but I'm severely claustrophobic and cannot tolerate it. I want to know whether there are acceptable alternatives I can use for ongoing surveillance, such as tumor marker tests, CT scans, sigmoidoscopy, colonoscopy, biopsy, etc. So yes, I'm aware of this issue, and they're different. This is not a blanket answer for everybody. This is like, depending on your situation, each person will need to speak to the individual consultant. I would say that yes, we can definitely use tumor markers as surveillance. We can definitely use blood tests as surveillance. We can definitely use CT scans. It's just that we're trying to go for the gold standard, right? We're trying to go for the one that will give us the best answer possible. And the MRI scan is just known to be more sensitive than the CT scan. Right? So that's why we recommend the MRI. But if you can't have the MRI, again, it's not your fault. I think even sedation has been a problem. So we'll have to do the best we can with monitoring you with the CT scans and with tumor markers as well. Yes, colonoscopy will also be part of that monitoring. So we can work around your particular situation and do those instead. And then another question, please, Tolu, tell me when to stop, because I know Dr. Adaure has to come on with her segment as well.
So I believe you can take, I believe you can take the last question, and then we would have Dr. Adaure take her session.
Okay. So it says, can cancer be completely cured, or is it something that will be managed for life? Cancer can be completely cured, definitely. It can be completely cured, especially if we catch it at an early stage. So in general, cancers that are caught at stage 1 or stage 2, at that early stage, the chances of the person being alive at 5 years is above 95%. Okay, so the chance of that person still being cured at 5 years is above 95%. When you then go to 10 years, 15 years, 20 years, we don't have as robust data because we generally follow people up for about 5 to 10 years. But there are people definitely who have had cancers. Those cancers have been removed and treated appropriately, and the cancer never comes back. So yes, cancer can definitely be cured. So that's the answer to that.
All right. Thank you so much, Dr. Iwuji. And I hope that for everyone who asked a question, their questions were answered. Dr. Iwuji, do you still want to say something?
I actually do. So there's one last question because Dr. Adaure has very graciously said that there's no rush on her side, and I do want to address this. Depression in cancer journey. How and what is Lakeshore doing to better manage her patients in this regard, while also using this rare opportunity to better strengthen patient-oncologist partnership? Excellent, excellent question, and I think I might need to call on Dr. Tolu Animi to update me on some of this, but Lakeshore is very, very, very interested in trying to support patients who are going through the depression and cancer journey. We are at this moment actively trying to engage with psychiatrists and psychologists to help support our patients in the cancer journey. We've actually even set up a questionnaire about this so that we could get not just assume from our side what patients need, but actually to ask you who are going through the cancer journey, how can we support you better in this? And based on the feedback we got from that questionnaire, we're actually trying to actively engage appropriate services for that. One of our previous cancer survivors very generously donated some funds for psychological support to cancer patients. And so we're trying to use those funds. And I think at this point, Tolu, you can correct me if I'm wrong, we're trying to figure out how best to make the most of those funds, whether it's for individual services or group services. And, we can't do it on our own. We would very much like for our patients who are having issues to obviously let us know that they're having those issues so that we can refer them appropriately. But the issue we found for a lot of people is there's so much of a burden with the financial cost of just the chemotherapy or the treatment for the cancer that sometimes it's difficult for them to also carry the burden of paying for the psychological support. But we are doing our best to try and use those funds that have been donated to support in that situation. But please, if you are struggling with that side of things, please let us know. And like I said, because for the breast cancer survivors, not even just breast cancer, any kind of cancer, you can have depressive symptoms, but particularly if the treatment you were given pushed you into the menopause. For men, if the treatment you're given lowers your testosterone levels, all those things can lower your mood and make you at higher risk to have psychological impact. So we should do more about this, and I'm really glad that question was asked. We will continue to try and push for that. I don't know, Tolu or Dr. Tolu Animi, do you have any feedback you want to give about what we're doing? Thank you.
Yes, thank you, Dr. Iwuji, for mentioning that. And yes, we do have some funding support for those who require psychotherapy, but you would need to just reach out to us via our email, info@Foundation for Cancer Care, if this is something you're interested in, and we would let you know what is available. So you can just send an email to us at info@foundationforcancercare.org if this is something that you need. I believe Pelumi can help put the email in the chat box so that people can easily pick up on that. All right. So I think at this point, we'll just allow Dr. Adaure to get into our session. She's going to just briefly, share a few things with us about something she's working on and how we can be a part of it as cancer survivors. So Dr. Adaure, over to you. Thank you.
Hi, thank you all for having me. And Dr. Iwuji, always a pleasure hearing from your end as well. It's a great presentation and really amazing questions. Let me just start sharing my slides. One second. Okay. You guys can all see my slides, right?
Yes, we can.
Okay, great. So I really want to say thank you to the Lakeshore Cancer Center and the Foundation of Cancer Care for allowing me to give this presentation to you all. I know it takes time, and I know this is a safe space for you all. My name is Dr. Adaure Nwaba. I'm a fourth-year plastic surgery resident at Northwestern University in Chicago, Illinois. And I learned about your cancer center from Dr. Lumadi. She's worked a long time with the Cancer Center, and was one of the co-investigators for the COSFIN project that Dr. Iwuji was talking about before. And I was really inspired by the work that's being done here. Breast cancer has a special place in my heart, both because one of my aunts had breast cancer. She's doing well, but she's one of the survivors of breast cancer and had a lot of decisions to make when I was a medical student. So I understand it intimately from a family member's perspective, and then also from our own patients that we deal with in terms of reconstruction. So the project that I developed was in conjunction with everyone here. It's called the Evaluation of a Breast Cancer Survivorship Program, and or also known as a support group. So these survivorship programs are essentially just like this Dewdrops group, support groups for women and their families living with or affected by breast cancer. It provides an opportunity for patients to help them reduce stigma, to help increase support that you guys can have with each other, because you guys all have your own experiences with different providers, having learned about your diagnoses and all these other things, so you can support each other in that way. And then also in terms of how to navigate the use of the resources that are available to you, which sounds like it's been a topic even going through this presentation today with the questions that you guys have all asked Dr. Iwuji. Living with breast cancer is multifactorial. So there's so many things that you're navigating. There's various treatment options. There's various financial constraints, treatment side effects that include many things. You guys already touched on some of the mental health aspects of it. There's also treatment-related fatigue and something called lymphedema. Some of you may know it, some of you may not, but sometimes that can present itself as pain or stiffness or swelling of one of your hands because if disease has moved into your lymph nodes and that affects the circulation in your arm, then it can cause some of those side effects. Also, some of the treatments can also affect that, such as radiation, because it changes the tissue that you have. It also means that there's various support systems that you need to be in contact with when you have breast cancer, because there's so much going on that it's difficult for one person to handle everything without support and care. And then there's, of course, part of what this conversation was about, surveillance care. There's also many resources through the breast survivorship program that patients can have. This can include patient education and advocacy, emotional and mental health support, as has been touched upon today, patient navigation support, which has also been touched upon today, whether it's learning about different physicians that you can talk with, understanding what are different surveillance methods that can be used for your disease pathway and who you should be in contact with. There's so many different things that you guys have to navigate, and it can be difficult to understand who you're supposed to go to and when. Additionally, financial navigation support, and then learning about additional treatment options and rehabilitation services. And this can include some of the buckets of nutrition, physical exercise, mental health therapy. So there's just many different ways that a breast survivorship program and your support group can help you. So the project that I developed essentially wants to hear from you all about how you guys are using this support group and what additional resources can be provided through the support group. So this project is for you and by you. And project doesn't take very long. It's about 5 minutes of an online survey, and then also 5 minutes of an interview. The interview will be de-identified. So we'll have you do an interview that you don't have to show your face, can just be your voice. And then we would also write out exactly what you say so that we can later delete the voice copy as well. Once you've completed both aspects of the survey and the interview, then you'll receive a stipend of 30,000 Naira through the Foundation of Cancer Care. So how can you be involved? There's a form that I'll have listed here through a QR code, and then I'll put the form in the chat as well. So you can be contacted in future for this research study. We're hoping to have it start within the next month or two. So we'll contact you when it's available. Upon completion of the survey and interview, your stipend will be provided. So that's why it is important to fill out this initial survey so that we know who to provide the stipend to, and the foundation can reach out to you to figure out how that can be sent. And then after that, these results will be shared with the Lakeshore Cancer Center and the Foundation for Cancer Care teams and you all as patients. We want the results of this to be helpful to you directly and helpful to the center and the Dewdrop support group through the foundation. We want to be able to use these results to provide the necessary resources and make sure that things are being tailored to the things that affect you the most. You can contact me at this email for any questions or concerns that you may have. Of course, you can drop any questions in the chat box as well if you have any that come to mind today. And I just want to thank you for your involvement. Your voice matters. Research that prioritizes you and also listening to the concerns that you bring are really the only way that programs can meet your needs. And it's the only way that we can also generate support for such an amazing center and the support group to help. I know that there are some people here who maybe aren't breast cancer. Unfortunately, the project is only for breast cancer patients, but hopefully it can be helpful to everyone. So you can use this QR code, and then I'll also put the link in the chat. Are there any questions?
Okay, thank you very much, Dr. Adaure. So please, if we have any questions for Dr. Adaure regarding this particular research, we can take one or two questions. But she's already shared the link where we can sign up if we're interested in participating in this research. She's put that in the chat box so we can pick it up. What we can also try to do is to put it on the Dewdrops platform and also share via our emails for those of us who attended the webinar, so that just in case you want to participate and can sign up. All right.
While people are potentially typing their questions to Dr. Adaure, can I just answer this other question that came up?
Yes, please, Dr. Iwuji.
The question is, how do we battle the effects of that chemotherapy has on nutritional status of cancer patients? And do we have any dietitian on ground to improve that? I think it is very difficult because we know that when people are going through the cancer journey, it's easy for them. It's common that they lose their appetites. The chemotherapy can change their taste buds, which can make it difficult for them to want to eat as well. I think one of the biggest issues that makes it even more difficult is if people try and change their diet too much while they're having the chemotherapy. During the chemotherapy itself, I think people should just eat what they're able to eat. And then it's after the chemotherapy is finished that you can then try and have a more healthy diet. If anyone is going through chemotherapy and they're struggling with let me stop using chemotherapy, going through treatments, because there are different types of treatment. If anyone is going through any type of treatment and they're struggling with their diet, then yes, we do have, it's taken us a long time to find a dietitian that meets the standards that we would have at Lakeshore. But we have got a dietitian now. So if anyone does feel that they would benefit from seeing a dietitian, yes, we're able to refer the person to the dietitian. They're not on ground, but we can do the referrals and then they can come and see you at Lakeshore. And I think that's very important because sometimes it's difficult to know what to eat or not to eat. But what I would say is it's not a time to, when you're in the midst of the treatment and your appetite is low, it's not a time to start cutting things out. But when you finish the treatment and you're starting to now try and build up to your normal, feeling more like your normal self, that's when you have to be careful that you have a normal, healthy diet. So yes, we have the dietitian. And the other thing is we can use supplements. So we have things like Ensure and collagen that we can give to people who are struggling with their nutritional status. So we do have that to boost the nutritional intake for our patients.
Okay. All right. So thank you so much, Dr. Iwuji. I can't see any more questions.
Can I ask Dr. Adaure a question? Just because.
Yes, please.
Okay. Just for the interest of the survey, how long do you think the whole process will take? Like, how long what's the time frame you're aiming to complete it in and get the results back to the dewdrops people that participate?
Yeah, so the actual survey takes less than 10 minutes to complete for each patient. Once we have all the data, it should take us maybe less than a month in order to get the results, back, analyze it, and then talk with you guys about next steps.
Thank you.
All right. Thank you, Dr. Adaure. Thank you, Dr. Iwuji. And yeah, so I think at this point, if we don't have any more questions, we will just wrap up. So we have a post-webinar survey that we would also put in the chat box so that we can get your feedback on how the webinar has been so far. So you would find that in the chat box and you can please respond to it as we close out. But I would just like to say a very big thank you to Dr. Iwuji. Thank you for taking time out of your very busy schedule because we know how busy things get for you, but we're grateful that you were able to, take out time to have this interaction with us. And, this conversation is truly, truly an important one. Thank you for all the points that you shared. And, for me, I think what I took out of it is the fact that it starts at the very beginning. So it starts with also getting the right team, ensuring that you are attending the right facility and you have the right professionals that are actually, in charge of your care, because that would really determine the outcomes of your treatment. And then all the lifestyle options that you gave, especially when you talked about exercise and how much exercise can actually do in terms of improving chances of having a longer time, without cancer, reducing your risk for recurrence. So we're really, really grateful for all of those tips. And I believe that we have certainly learned a lot. If we have any additional questions that we've not been able to ask during the course of this session, please, you can always reach out to us via email, or if you are on the Dewdrop support group, you can also reach out to us and, we'll be able to get your questions across to the speakers and give you a feedback. So, Pelumi, please, we're still waiting for the poll. Please, can you put it up so that we can respond to the closing out poll? All right. So we'll just say a very big thank you. Thank you also, Dr. Adaure. We hope that you get the participants you need for the research, and we're really looking forward to, the outcomes of that as well. So without much ado, just like to say thank you. But yeah, everyone, and we wish you a really, really beautiful evening ahead. Thank you
so much. Thank you for everyone taking the time to come and listen as well. I appreciate it. And thank you, Dr. Adaure, for also taking the time to join us today.
Pleasure. Thank you all for having me.